Good morning, everybody. Looks like our anchor person is gone out somewhere. So before announcing, I'll just start with the next one, which is the deep cervical plexus. We are in this session we are dealing with, are these blocks obsolete? So we should be using these block or not using this block, or where we should use this block. Same way as ankle block, deep cervical plexus is formed by C1 to C4. The C1 doesn't divide into any branches, but C2 to C2, C3 and C3 will divide into upper and lower branches. It forms three loops, and basically it supplies the cutaneous areas also and the muscular area also. Cervical plexus lies posterior to the internal jugular vein and the sternocleidomastoid muscle, and above scalenus medius and levator scapulae. Except C1, rest of the roots divided into upper and lower branches. It supplies the back and sides of the head, front of the neck, and also the phrenic nerve, which supplies the diaphragm. So we should be very careful while giving the deep cervical blocks. So this is the cervical plexus, where you can see that it supplies the cutaneous supply also and the muscular supply also. So what are the branches of cervical plexus? Superficial and deep. The superficial are either ascending branches, that is lesser occipital, greater auricular, or nervous cutaneous scoli, or the descending branches, that is supraclavicular, medial, intermediate and lateral. As you can see in this picture, that cutaneous branches supply the neck, the back of the neck, below pinna, the anterior part of neck, and over the clavicle. So these are the ascending branches, and these are the muscular branches. Which muscles are supplied? Sternocleidomastoid, trapezius, levator scapulae, scalenus medius, and scalenus posterior. Why this is important? Because if we are giving a cervical plexus block, do we require relaxation, or we require only a cutaneous sensory block to be done? The other branches, like communicating branches to spinal accessory nerves. The muscular branches are going to the following muscles, that the prevertebral muscles, infrahyoid muscles through ansa hypoglossal, diaphragm from C4, and the communicating branches to vagus, hypoglossal and sympathetic nerves, and the phrenic nerve, which we told just now. These are the muscular branches. So what is cervical plexus block? This is a regional anesthesia which can be used for surgical procedures in the neck region. It is an effective cervical plexus block, produces anesthesia over the neck, occipital region, shoulder and upper pectoral region. It is divided into two parts, the superficial cervical plexus block and the deep cervical plexus block. Superficial cervical plexus is, we can block it on the posterior border of sternocleidomastoid at the midpoint. We can infiltrate along the lateral border of sternocleidomastoid if you are not using ultrasound. If you are using ultrasound, you can actually locate all the nerves at the midpoint or around midpoint of lateral border of sternocleidomastoid. The complication with superficial cervical plexus block is rare, but sometimes you can get a phrenic nerve block or a hematoma. The deep cervical plexus can be blocked at C2, C3 and C4 root levels. It is in very close proximity to vertebral artery, vagus, phrenic nerve and other carotid and other great vessels. So there are multiple complications also associated with it, because it is also very close to the vertebral column. You can get a epidural block. You can injure the vertebral artery. If you inject directly into the vertebral artery, the patient will get convulsions because the drug is going directly to the brain. You can cause a sympathetic block leading to Horner syndrome, and phrenic and vagus can also be blocked. But normally if phrenic is blocked, it is only partial because C4 level is blocked, C5 and C6 is not blocked. Or if cervical hematoma occurs in the patient who are on anticoagulants, then it is a dreaded complication. You can get quadriplegia. There are multiple papers which have come, like superficial and deep cervical plexus, the technical consideration. They said that the sensory component of the cervical plexus can be blocked separately and easily with a superficial cervical plexus block. But if you want a motor blockade, you require a deep cervical plexus block. In another study which had come in anesthesiology in 1998, prospective randomized comparison of deep and superficial cervical plexus block for carotid endarterectomy. They performed carotid endarterectomy satisfactorily under superficial and deep cervical plexus, but they found no difference in the two, and there was no difference in the amount of drug which was used. In another study which came in anesthesia analgesia in 2000, the comparison between superficial versus combined, that means superficial plus deep cervical plexus block, it stated that carotid endarterectomy may be performed using cervical plexus blockade with local anesthetic supplementation by surgeon during surgery. They have to supplement deep in the deep layers and also between the pinna and the mastoid process. Superficial cervical plexus block or combined block are both effective, but they found no difference between the two techniques. In another study which came in British Journal of Anesthesia, deep and combined blocks were associated with higher serious complication than only a superficial block. One more study said that superficial cervical block shows same efficacy, but the complication and incidence or complication with the deep block are higher. The type of block does not influence the final outcome of the patient. One more study by Gay et al. Said that the superficial cervical plexus block is the technique of choice for anterior neck surgery. If we see oral or maxillofacial surgery, there was a study by Persandis et al. They said that all patients showed complete cervical plexus nerve block. No patient required analgesia within 24 hours. That means a very good postoperative analgesia was there. This was for the anterior neck dissection. And the two cases of blood aspiration were recorded when giving the block. That means they might have punctured the vertebral artery. And no further cervical plexus block related complications were observed. So what have we learned from this? We have learned that the superficial and deep cervical plexus block are both effective for neck surgery. Motor blockade is better with the deep cervical block. So if we want to have a relaxation of the neck muscles, then deep cervical block has to be given. The complication rate is higher with deep block because of its proximity with the great vessels, the epidural space, etc. In surgeries where motor blockade is required, deep block is better. Ultrasound has changed little bit in cervical plexus. Okay, superficial cervical plexus can be seen very well. If you want to see the deep cervical plexus or transverse processes, C2, C3, C4 are seen, we can inject it near to it. But the studies have come out that there is no difference in the outcome and the success rate of the block using ultrasound or a direct technique in these cases. Thank you.